Hello and welcome to Leicester Spot Diagnosis, the page that uses social media to enhance peer-led medical education. I'd like to just go over the answers to a case that I posted a couple of days ago. There's been some good discussion on this and you pretty much got this, and I'd just like to reinforce what's been said. So this is paralysis of the third cranial nerve. I asked you what the diagnosis is and you got that right. That's brilliant. I've asked what the features are and you've pretty much got them all as well. So there's ptosis of the eyelid. So the eyelid is drooping. That's because the oculomotor nerve, the third cranial nerve, supplies the levator palpebrae superioris, which is the muscle that elevates the eyelid. If the finger wasn't there, the eyelid would be drooping down. It would be partly or fully closed. You can see that the pupil is dilated compared to the unaffected eye, and the eye is deviated outwards and to some degree downwards. The textbook will say that paralysis of the oculomotor will give you an eye which is deviated down and out. Things don't always happen in real life like they do in a textbook, but perhaps I can convince you with the eye of faith, no pun intended, that the eye is deviated ever so slightly downwards as well as outwards. Now I'd just like to mention what the top causes are. So an aneurysm of a blood vessel that runs close to the oculomotor nerve could compress the nerve and cause paralysis of the nerve. This could be due to diabetes, or it could be due to uncal herniation. And I'd just like to briefly talk about all three of those with the help of a few pictures that I have here. Okay, so this is the underside of the brain. The oculomotor nerve comes along here. It exits the brain. It has a fairly long course before it exits the skull up here somewhere. This is looking down into the brain, so the oculomotor nerve will be running in this sort of area, and then it passes into this red area. Indicates the location of the cavernous sinus, where there's various structures that pass through, and the oculomotor nerve runs in the lateral aspects of the cavernous sinus, disappears underneath this ridge, and exits the skull through the superior orbital fissure. I'll show you on a CT scan the location of the cavernous sinus. It's this area here. You see these black circles? This is air within the cavernous sinus. Notice it's the same density as the air within the paranatal sinuses and the petrous part of the temporal bone in the mastoid air cells. This is abnormal. It shouldn't be there. But because air is so easy to spot, and air within the cavernous sinus is very helpful for me to point out to you exactly where the cavernous sinus is. So the oculomotor nerve will be running in the lateral aspects of the cavernous sinus and exiting the skull through the superior orbital fissure. Now let's suppose you've got some kind of problem, some kind of pathology that's putting pressure onto the cavernous sinus, and it's going to put pressure onto the structures within the cavernous sinus. So let's suppose this is a cross section, this is medial, this is lateral. So you can see here that there is the internal carotid artery. A little bit further posterior, you have the posterior communicating artery. So let's suppose that there was an aneurysm of one of these arteries, and it was putting pressure onto the nerve. It would compress the nerve, it would stop it working, and you would get some of the signs that we've talked about. However, the order of the signs is important, or at least it is in theory. Now the nerve fibers that supply the pupil, the parasympathetic nerve fibers that supply the pupil, are on the outside of the oculomotor nerve, whereas towards the center of the oculomotor nerve are the fibers that supply the extraocular muscles. So if there is some kind of compression of this nerve, the outside fibers will be affected first, and the fibers towards the center affected afterwards. So if there is compression from an aneurysm, or let's say there's a bleed in the brain and it's causing compression, then the pupil may increase in size first before there is deviation downwards and outwards of the eye. Okay, so that's an aneurysm. So let's suppose that it was due to a bleed in the brain. Now this is the uncus. I was always confused about uncle herniation. Is that uncle as in Bob's your uncle, as in auntie and uncle? No, the uncus is this area of the temporal lobe of the brain, and when it herniates, therefore it's referred to as uncle herniation. Slightly unusual sounding, I know. So the oculomotor nerve is running in this sort of direction and in this sort of area, and when there is pressure from the bleeding, the uncus is pushed onto the oculomotor nerve is compressed, and you get some of the signs that we've talked about. The other one is diabetes, and diabetes typically affects nerves from the inside out as opposed to the outside in. So let me give you 3 hypothetical scenarios. Let's come back to this patient. Let's say that they are a 21-year-old male who's been involved in an RTA. He's been pulled out of a wreck of a car and is coming to A&E with a low GCS, and this is what you see when you look in his eyes. You're not going to be thinking aneurysm or diabetes. You're going to think a bleed in the brain, you're going to think head injury, a bleed in the brain, and uncle herniation. Let's suppose this was a 70-year-old gentleman who's had diabetes for 15 years, and he presents to his GP and says, oh, my eye was wonky, and then after it was wonky, pointing downwards and outwards, then the pupil got bigger. That would fit with diabetes. Or let's say that this was a middle-aged or elderly person who doesn't have diabetes, who doesn't have a head injury, and has said that I have no pain, no symptoms, I've just noticed that one eye is bigger than the other. And in this situation, perhaps an aneurysm of the posterior communicating artery or the internal carotid artery would be more feasible. So there we are. We've covered third cranial nerve palsy, we've looked at the features of it, and we've looked at the top causes, which are diabetes, uncle herniation, and aneurysm, and how the order of the symptoms and understanding the anatomy of the location of the different types of fibers within that nerve help you determine which one of those top diagnoses that it could be. Thanks for listening, and don't forget to find us on Facebook and to like the Leicester Spot Diagnosis page to keep updated with future cases. Thank you.